Bismillah ar-Rahman ar-Rahim. In this video, I will speak about postoperative breathlessness. The pulmonologist is often asked to see patients postoperatively who have become dyspneic following an operative procedure. The risk of pulmonary complication is greatest with thoracic or upper abdominal surgery when a degree of pulmonary dysfunction and consequent breathlessness due to atelectasis is inevitable. Causes of postoperative dyspnea include atelectasis, pneumonia, thromboembolic disease, pulmonary embolism, respiratory failure, metabolic acidosis, myocardial ischemia, myocardial infarction, cardiac failure or fluid overload, acute respiratory distress syndrome, phrenic nerve damage causing diaphragmatic paralysis, fat embolism, laryngeal spasm, anemia, myasthenia gravis crisis precipitated by anesthetic agents, opiate overdose or anesthetic agents which can cause respiratory failure. Assessment of the patient of postoperative dyspnea include important assessment of situation of the patient, and if the patient is acutely unwell needing immediate resuscitation and ventilatory support should be ruled out. And we should ask about comorbid disease and past medical history, especially pulmonary, cardiac, or thromboembolic disease, type of the surgery, because the pulmonary complications are greatest with thoracic or upper abdominal surgery. Time since surgery, because there are early complications which occur in hours and later complications occurs after some days. Management of the patient including the initial investigations, which include the following: investigations of patient with postoperative breathlessness include ABG, ACG, chest X-ray, and sometimes we consider HRCT or high resolution CT, CBC and the clotting screen, urea and electrolytes and bicarbonate, D-dimer level, and CRB. Treatment of postoperative dyspnea will be detected or determined according to the cause. If there is basal atelectasis, which is common in smokers and the following abdominal or transthoracic procedures, mucus in bronchial tree causes small airway obstruction and subsequent alveolar air resorption, and collapse of lung segments, let's say mucus due to mucus plugging. In that situation, adequate analgesia to encourage expectoration, and we use nebulized saline and chest physiotherapy and deep breathing, and we can consider bronchoscopy to do suction of the secretion. Pneumonia. If fever and chest signs, give antibiotics for hospital-acquired pneumonia, and adequate analgesia to encourage expectoration and chest physiotherapy. In pulmonary embolism, oxygen is required at measure A gradient on blood gas. Start treatment dose of unfractionated heparin if not contraindicated by operation, and the range for VQ scan or CT pulmonary angiogram and check D dimers, although unhelpful unless if negative. If extreme, consider urgent CT or echo and thrombolysis. Respiratory failure because of opiate overdose or anesthetic agents causing neuromuscular block, not reverse it. In that situation, we will use oxygen therapy and we will consider antidote for opioid analgesia, which is naloxone, that will reverse the effects of an opioid overdose if administered in time. Metabolic acidosis, we will treat it according to the reason, either renal failure or sepsis. And if there is myocardial ischemia or MI or acute coronary syndrome, we will consider thrombolysis or treatment of ischemia or acute coronary syndrome by low molecular weight heparin and protocol of treatment of MI. And heart failure, we will consider oxygen saturation and diuretic, IV furosemide, and putting central line inotropes if required, and the echo to assess left ventricle. In ARDS, will consider mechanical ventilator and in phrenic nerve damage, diagnosis on lung function tests, chest X-ray, and clinically decreased diaphragm movements. We will advise tilt whole bed, to stay head up when sleeping, and the phrenics may recover but can take about 2 years. In fat embolism, we'll consider oxygen therapy, eye fluid, and supportive care. And laryngeal spasm, we will consider reassurance and oxygen if required. The anemia will be treated by cross match and transfusion of blood if required, and treatment of the cause of anemia. And myasthenia gravis crisis precipitated by anesthetic agents need intubation and ventilation, and stop all anticholinesterase, and consider plasma exchange and IV immunoglobulin, and the urgent urology input. Lastly, we will mention the most causes of post-operative breathlessness we should put in our mind: infection and atelectasis, pulmonary embolism, left ventricular failure, and exacerbation of underlying disease such as COPD. That's all, and thank you.